All right, let's jump right into this fascinating clinical explainer. Today, we're unpacking a really incredible pediatric medical mystery from Massachusetts General Hospital, where a terrifyingly low vital sign sent doctors on a hunt for a massive hidden culprit. We're going to break this case down just like an attending physician would, working logically through the presentation, the imaging, and the pathology to figure out exactly what happened to this 12-year-old girl. Here's our clinical roadmap for the explainer. We'll start with the clinical presentation, try to solve the hypoglycemia puzzle, build our differential diagnosis, localize the tumor, dig into the surgery and pathology, and wrap up with the medical takeaway. Section 1. The clinical presentation. So picture this terrifying morning. A healthy 12-year-old girl, totally fine the night before, suddenly can't be woken up. When she finally opens her eyes, she's speaking nonsensically and slipping in and out of a stupor. Upon arriving at the emergency department, her temperature was an icy 35.4 degrees Celsius, but the real alarm bells started ringing when they checked her blood glucose. It was 30 milligrams per deciliter. 30! To put that in perspective, a normal range is 70 to 110. She wasn't just feeling faint, she was in a severe, life-threatening metabolic crisis. Clinically speaking, she perfectly hit all the criteria for Whipple's triad. You've got the classic symptoms of hypoglycemia, the documented low blood sugar, and, crucially, when the ER docs gave her an IV push of glucose, her symptoms temporarily resolved. That cemented our primary clinical problem right out of the gate: severe symptomatic hypoglycemia. Section 2. The hypoglycemia puzzle. Now, this is where it gets really weird. The lab data collected during her actual hypoglycemic episode, what endocrinologists call the critical sample, revealed a huge paradox. Her beta-hydroxybutyrate levels were basically non-existent. Normally, if your blood sugar tanks, your body starts burning fat and produces ketones, right? The absence of ketones tells us there's a massive insulin effect happening because insulin stops fat breakdown. But when the lab actually went to measure her insulin and C-peptide levels, they were completely undetectable. 0. Her body was acting like it was flooded with insulin, but there wasn't any actual insulin to be found. Section 3. Differential diagnosis. So we have to figure out what's causing this intense insulin-like effect without the actual hormone. We got to systematically cross off the usual suspects. An insulinoma? Ruled out, because we'd expect high detectable insulin. Factitious hypoglycemia, like secretly taking diabetes meds? Same thing, the lab's signature doesn't match. Congenital hyperinsulinism usually shows up in babies, not out of nowhere at age 12. An insulin autoimmune syndrome? Super rare, doesn't really fit this fasting profile, and she had literally no risk factors. And that brings us to the smoking gun. They tested her insulin-like growth factors. Normally, the ratio of IGFI2 to IGFI is less than 3 to 1. Her ratio was a staggering 8.6 to 1. This completely confirmed a very rare paraneoplastic syndrome known as non-islet cell tumor hypoglycemia, or NICTH. Basically, her body was churning out this high molecular weight, big IGFI, a rogue protein structurally similar enough to insulin that it was hijacking her receptors and just totally crashing her blood sugar. Section 4. Localizing the tumor. With NICTH confirmed, the medical team knew for sure that a hidden solid tumor was pumping out this big IGF-2. They immediately did a CT scan to find it, and honestly, the discovery was staggering. The imaging revealed a solid, enhancing intraperitoneal mass measuring an unbelievable 28 by 21 centimeters. It was taking up a massive portion of her abdomen and pelvis, just quietly growing completely under the radar until this chemical imbalance forced it into the spotlight. They followed up with an MRI to get a better read on the soft tissue, and it really painted a vivid clinical picture. The restricted diffusion told us this was an aggressive, densely packed hypercellular tumor, and the T2-weighted scans highlighted all these complex cystic features, showing exactly how this giant growth was physically displacing her normal organs, literally just shoving her intestines and ovaries out of the way without actively invading them. Section 5. Surgery and pathology. Now, you don't just rush a 12-year-old into the OR with something this massive. The pediatric oncology team took a very structured, professional approach. First up, a core biopsy, which showed a spindle cell proliferation with smooth muscle markers. Then, they ran molecular testing to see if they could shrink it first with targeted systemic therapy. When that came back with no actionable targets, they made the call to proceed straight to an exploratory laparotomy for a full surgical resection. The surgeons managed to safely remove the entire mass, along with a small attached segment of her colon, all in one piece. And you won't believe this. When they put it on the scale, It weighed 5 kilograms. That is over 11 pounds. The final pathology, a benign cellular smooth muscle tumor. So thankfully, despite being absolutely enormous and metabolically aggressive, it wasn't cancer. Section 6, the medical takeaway. For me, the most incredibly satisfying part of this whole case happened right in the operating room. Before surgery, she needed a continuous IV of dextrose just to stay conscious. But literally, the exact moment that 5-kilogram mass was detached and removed, her blood glucose normalized. Just like that, it was immediate proof that the tumor was the sole driver of that life-threatening hypoglycemia. Which brings us to a really profound final thought about the sheer resilience of the human body. Think about it. How does a child carry around an 11-pound mass in her abdomen completely unnoticed? No severe pain, no obvious bulge. It wasn't the physical tumor that brought her to the hospital. It was a super rare chemical alarm bell that finally triggered a metabolic emergency. It's just a fantastic reminder of why thorough, structured clinical investigation is absolutely vital. Thank you so much for joining me for this medical explainer.